forward. So you will have to unmute yourself. Yeah.
Yes.
Yes. Dr.Sharan Srinivasan has studied from Bangalore Medical College and Research Institute, and he has performed major brain and spine surgeries. He's a member of national and international professional organization, and his work not only in the field of medical, but contribution towards the legal fraternity also cannot be done away the way which he has contributed. So I just wanted to ask whether you had logged in through this thing, a password, or straight away with the link, because I was facing a difficulty somehow today.
I logged with the link, no password.
Okay, because password was showing, and that is why there was some delay. So without taking much time, I would request Dr. Sharan Srinivasan, who has agreed to share his knowledge, to put the things forward in the right perspective. Right, sir?
Thank you very much. At the outset, I want to thank Justice Chandrasekhar, retired judge from the Karnataka High Court, for taking this initiative and connecting me to Mr. Vikas and Beyond Law CLC to share my, the little experience I've had in motor vehicle accident disability assessments. It is 4:18 right now on my clock. I hope I can speak for an hour because this is a very tight.
Definitely. No, perfect. Because of that password, I'm saying that there was some difficulty. I'm just checking it out.
Fair enough. I just want
to that participants would also feel difficult.
Somebody has planned something. I'm going to share my screen and go right away.
Screen sharing. Hello. It's at me loud.
Yeah. So I hope all of you can see my screen.
Yeah.
Yeah. So I also, apart from being a neurosurgeon, I also run one of the best neuro rehab centers in India called NEWRO. It's a neuro with a W, where we have redefined the way the whole neuro rehabilitation happens after head injury or stroke. And I have my own patent for the curriculum for advanced neuro rehabilitation. We already have the Indian patent. We are going across for the global patent. So, oops, what's happening? So I'm talking about TBI and resultant disability, how to do the medical legal assessment. I'm in the hardware business as a neurosurgeon. What is this hardware business? Like you see here, there's a CT scan of the brain, of the head. The white margin is the skull. All the gray is the brain. And what is the large white ball that you see on both sides is a large clot on the left side of the brain on the side. So this is a patient following a road traffic accident, came with a large clot inside his brain, what we call as a temporal contusion. Now, I've obviously went and operated this. So post-operatively, you see the scan here, same skull, there's a gap there because this bone has been removed and there's no white ball, which means operation successful. But the question is, what is the patient condition? What you have to realize very early is physical healing is not necessarily equal to a good functional outcome. The ideal goal is we need to bring the patient back to 100% pre-morbid level of functioning. But the question is it possible in every patient? When I do my talks to non-doctors and people not understanding the brain too much, I'm sorry that I'm virtual, but I don't know whether you can actually see me. But when I give my talks, I start my talk by showing the pen and ask everybody, what is this? And they say it's a pen. And then, I ask them, is your eyes telling you it's a pen or brain telling you it's a pen? And usually it's a 50-50 answer. 50% said eyes, 50% said brain. The people who say brain are saying the answer, giving me a wise answer because the neurosurgeon asking the question. So I normally,
Dr. Saab, you are visible, though of course the screen is short, but you are visible.
I get that. Thank you. So I always ask one of the persons who have said eyes. I said, sir, imagine if you are sleeping now, and I open your eyelid and physically show the pen. Do you see the pen? And they said no. And I said, are you blind? They said no. Then why don't you see the pen? Because the eye is on, but the brain is off. So similarly, I asked the question, is your tongue telling you Vanilla Ice Cream or brain telling you Vanilla Ice Cream? Is your ear telling you Sonu Nigam song or brain telling you Sonu Nigam song? No, the reality is, do we really see with our eyes, hear with the ears, smell with the nose? That's what I'm saying. The sensations are transmitted by all these organs, but the interpretation happens in the brain. So the very important thing is, I'm in the hardware and software business. This is the only organ, before I go to this. So think about it. You have, if you put your kidney to me, same susu, my kidney to you, same susu, your heart to me, same dub-dub, my heart to you, same dub-dub. I'm not degrading any other organ. but they do the same vanilla flavored activities for all of us from the day we are born to the day we die. But if you put your brain to me, it can't do neurosurgery. If I put my brain to you, it can't do the the legal work that you guys are doing. That means the hardware is the same, the software is different. This is the only organ in the body which has different software, which is individual to each of us. So like you said, we know what is the hardware and the software as far as the computer systems and either the mobile phones are concerned. In the nervous system, the hardware is the nervous system, which structurally looks more or less the same for all of us. If we do an MRI scan for all of us, the brain looks absolutely the same, plus minus a little bit of small changes in the shape. It does not tell it's a senior lawyer's brain, it's a judge's brain, it's a neurosurgeon's brain, it's a housewife's brain. It doesn't say any of that. But the software is individual. It's like the same Apple phone or the Android phone all of us carry, but the phone number saved is different, the files saved are different, the photographs and videos saved are different. So I ask everybody this question next: what's your brain's operating system? Everybody knows Android and iOS, but what is your iOS operating system? Is it the same? If not, who decides the operating system? Who uploads it into our hardware? Who provides the frequent updates? Who decides which new software needs to be downloaded and when to provide these? And if these updates do not happen, what is my fate? This is a very important thing. I think with the smart devices today, it's very easy for somebody like me to explain this whole process. So I'm going to ask you this question: what is this? And for want of interaction, I know the muting, I will say the answer. This is something in Chinese, but most of us do not know the answer. The first statement is good morning. The second statement is brain disability. So what am I trying to communicate is what the brain does not know, the eyes can't see. So let's go for a look at this system in the brain. This is the brain on the side view. The ball is the eyeball, and you see the eye nerves, it's transmitting all the way to the back of the brain. All the way now. And then you see, why is it so complex? Because vision is one of the most important functions for the human body, for human brain. Now, I want to tell you a story of a 45-year-old high court advocate. This story happened when I was training to be a neurosurgeon about 22 years ago. For 2 months prior to showing up in our emergency, he had repeated accidents to the right side of his car when he was driving. And in all, he had 17 accidents to the right side of his car. And then when I asked the question, they said, when he would argue in the court, he would hold the paper slightly to his left and not straight in front of him. But nobody really gave cognizance to what was happening. So for 1 month, he had some speech disturbances that also he neglected. And that morning before he showed up in an emergency, he had multiple attacks of epileptic fits, became unconscious, came in a comatose state in the emergency, and a CT MRI done. He had a large malignant cancerous brain tumor in this area of the brain that is controlling the right-sided vision, because of which he was not able to see the right side of his visual field. And that is how early the brain had given symptoms, but we neglected it. So we have renal function tests, kidney function tests, liver function tests, pulmonary function tests for the lung, thyroid function tests, heart function tests. We don't have brain function tests. That's why all of us are happy. Anything to be tested only, we have to correct it at the end of the day. So you see how the circuit goes all the way from the top. This is the motor system controlling the nerves for the hand and the leg, right from the top of the brain all the way down. It's so beautifully constructed cables that is going down, carrying all sorts of information, the different parts of the brain. I'm not going into too much detail because this is actually a 6-hour talk. I've compressed it, so I'm going to give you the salient features. These lobes are further broken into smaller parts, and then you have all the different functional areas of the brain, which is the anterior speech area, the speech, the hand, the leg, the vision, everything is showed here. And now this is just one example. This is called the motor strip. This is the area of the brain right in the middle, which controls the entire motor movements from hand to leg. Affecting of this or its connections is what causes the right-sided weakness that we see in a stroke classically. But it's not arranged so simply. You see how it's very, very arranged in a very mixed way. It doesn't mean that it starts at the head and goes all the way down to the little toe. It's all, the God has designed it in a very interesting way, depending on how the different parts of the body interact with each other. You see the hand and the face next to each other, because that's when we speak. We do a lot of hand gestures for communication, and that's how it is. And look at this picture. This is the model of what a man's body would look like if each part grew in proportion to the area of the cortex of the brain concerned with it. You see how big the lips are, how big the tongue is, how big the hands are, especially the thumb. You all know the ecolalia story, and how small the rest of the body is. So you see, because the speech is so unique to human beings for communication, the hand is so complex to writing, to reading, to so many things that we do, they have disproportionately high representation in the brain area. So let us go quickly to the nervous system injury and the resultant dysfunction. The whole body, so whenever I have gone to the court, by the way, I have gone to the court more than 2,000 times in the last 12 years, purely as a social obligation, because I felt that no other injury causes as much disabilities, especially brain disability, brain injury, and because it's not being represented well in the court, the patients are not getting served well, and it's because of that I have been going to the court and trying to educate as many people as possible. In the court, I've heard these two things very commonly: what is the whole body disability, and what is the avocational disability. So I'm trying to keep it to the way the legal fraternity understands this. So in our world, whole body disability is what is the permanent physical impairment in neurological conditions, and how much of that impairment is causing an impaction on the avocational and functional disability, and this will vary from person to person. Let us look at types of head injury or brain injury. So head injury can happen to the scalp, to the skull, or the brain. So then on the spine, so we are dealing with three types of nervous system injury. First is the head injury, second is the spine and spinal cord injury, and the third one is plexus injuries or peripheral nerve injuries. We will go step by step. I will start with the head injury first. Number one is head injury or brain injury, what we call in the medical terms as TBI, a traumatic brain injury. So if you classify the types of head injury, we have it as scalp injuries, skull injuries, focal injuries, diffuse injuries, or a combination. So many times, what I have seen is what is visible injury means significant, what is not visible means not serious. So you can have a patient whose whole skin of the head is maybe pulled off, and they might have put 200 stitches on the brain, or on the scalp. But if the underlying skull and the brain was normal, it doesn't matter. Even if there were 200 stitches, there is no disability except cosmetic disability, if at all. It's very important. Skull fractures the same way. If you have a crack in the skull, which is undisplaced, without anything else happening, it will heal very well. Even if some of the skull fractures are gone inside, sometimes it causes cosmetic dysfunction, but if it goes inside and presses the brain and causes underlying brain damage, then it becomes serious. So let's go and take it one by one. What is the epidemiology of head injury or TBI? 80% of head injuries are called mild head injuries, 10% are moderate, and 10% are severe. And a majority, why is this important? Why is the court struggling, and why is this such a big burning problem? Is majority happens either in adolescents and young adults. And the second peak is in the elderly. Male versus female is 2:3:1. And in this country, India has the highest number of road traffic accidents in the world today. One in every 5 accidents happening in the world, the one is from India. The reason is, as a population, we're inherently indisciplined. We love to break rules. We love to cross the road on the wrong side, jump the signals and things like that. So I don't think this is going to get better at all. So traumatic brain injury or TBI, it produces both structural and functional modifications of the brain. The results are highly variable and complex. The effects of the injury could be more on the motor system, on the sensory system, on the cognitive system. It could be emotional, it could be behavioral, it could be autonomic, or a combination of all the 6. The injuries to the brain, in total traumatic brain injuries, could be physical because of an acceleration, deceleration injury, or translation process. If all of you in front of me, I would have shown you a skull. I don't have it now because I'm in the hospital. If you see the inside of the skull, the outside of the skull is so beautiful and smooth, but the inside of the skull is so jagged, so irregular, with such sharp edges. So when the brain moves inside the skull with the torsion injuries, the translational injuries, lot of shearing forces are put on the brain, surface of the brain. The brain is very delicate, and it goes, because it's floating in that cerebral spinal fluid, it undergoes a lot of traction injuries also. So apart from the physical injury that can happen at the time of impact, the other thing happen is chemical injuries. Brain has only two nutrition, oxygen and glucose. So for some reason, if the oxygen supply to the brain becomes less, or the glucose to the brain comes down during a head injury, and especially there's a damage on top of the damage that happens, and that can happen, that can add additional complications to an already pre-existing problem. And then if there's an open wound on the skull, sometimes we have seen the whole thing open, the scalp is open, the bone pieces have been lost on the road. We have seen mud on the brain, we have seen paint on the brain, we have seen hair on the brain, we have seen all these things. So when that happens, all that infection can get in and cause a brain infection like a meningitis, encephalitis. So sometimes a patient can have a combination of all these three, and all of them together can cause significant permanent injury to the brain. So like I said, the damage could be diffuse or focal or both. It could be at multiple prominences. I spoke about all of this. So what are the consequences of TBI? These are all old data, but just the data worth knowing. The direct and indirect cost of TBI in the US alone is more than $400 billion as per 1991 USD cost, which is much more today. Imagine the cost in India, as we have the highest number of RTAs in the world. The neuropsychiatric and neurobehavioral disorders are the most frequent complications in TBI. We will talk about that. The biggest problem for us as experts when we come to the court to give evidence for disability assessment is that many of these disabilities are not measurable. The nervous system is still a big challenge for most of the medical profession. So most of it is not measurable. Like I said, we have no brain function test. So some of that, whatever we can measure to some level, we try to measure. A lot of it is non-measurable. And that's when it's left to the wisdom of the court to take a decision based on a particular situation, what's going on. So how do we categorize the severity of TBI? So sometimes you have to know, was this a severe head injury or was it a mild head injury? So the moment you have head injury, which is significant injury to the brain, the patient loses consciousness. We call it LOC. So, and if the loss of consciousness is less than 1 hour, we call it as mild. If it's from 1 to 24 hours after the trauma, we call it moderate. And if it is more than 24 hours, it's severe. So just by the duration of the loss of consciousness, you know how much of the brain had not worked and for how long. Now, another way of classifying the understanding the severity of TBI is based on the post-traumatic amnesia. Amnesia means loss of memory. Now, if the loss of memory is 5 minutes or less around the time of the accident, it's called very mild. 5 to 60 minutes is mild. 1 to 24 hours is moderate. 1 to 7 hours is severe. 7 to 30 days is very severe. More than 30 days is extremely severe. We'll come back to this a little later to understand there are 2 types of amnesia. We'll deal with that. Skull fractures, like I said, by pattern, there are different things. Anatomical location, it can be on the convex to base skull fractures. The classical thing, base skull fractures is when people have bleeding from the ear or the nose. And we all know how serious that is. Many of us have seen, injured brain matter coming out from the nose, coming out from the ear when you have severe fractures. It's quite distressing to see all of this. The fracture can be open type, closed type. It can be in multiple pieces, or sometimes it can get depressed and get into the brain and actually injure the brain because pieces can be got inside the brain. I will not talk about this. There's a very important condition that I would want all of you to know is the condition called diffuse axonal injury, or DAI. Before the onset of MRI, it was extremely difficult to diagnose diffuse axonal injury. And in most situations, diffuse axonal injury used to be a post-mortem diagnosis. With MRI and with the better quality CT scans, we're able to diagnose it much better today. But this is injury patient condition out of proportion to the injury. In many diffuse axonal injury patients, you can have a normal looking CT scan, but you can have a patient who's deeply unconscious. So many times what happens, the accident has happened in a local smaller town in the city, far away from the city. A local CT scan is done at maybe in a diagnostic center, and that image is seen by the radiologist, and without knowing the full condition of the patient, many times they look at what is seen on the image and say normal, 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 normal. So when I go to the court to give evidence, and then they show me the insurance lawyer shows me this normal report and says, see, doctor, There's a CT scan report is saying everything is normal. Everything is normal means patient is normal. This is one of the biggest problems that we have to explain to the court and the petitioners lawyers and the insurance lawyers, that in diffuse axonal injury many times, if the quality of images are not so good, especially you can have a normal looking CT scan with a deeply unconscious patient. This is one of the very important messages that I want you to take home from today's talk. So diffuse injuries will not go too much into that. Like I said, deeply unconscious patient with a normal looking scan. On the other side, you can have a patient with a large clot in the brain. I still remember this patient of mine who came in a year ago from Andhra Pradesh. He had to drive 5 hours to reach our hospital. He had a road traffic accident, 35-year-old guy. He came with a big bandage on his head, which was completely soaked with blood. They told me there's an open wound there and, whatever it is. When I opened very carefully, they had already told me that some pieces of skin is missing. When I opened, the skin was missing, some bone pieces were missing. And when I turned the bandage out, I actually saw, damaged dead brain on the gauze piece, which came out. But you know what? That means that is how bad the injury was. But this man was conscious. He was telling me his name. He was telling me his address. This was focal injury versus a diffuse injury. So all kinds of dramatic things can happen. Now you see some of the CT scan representative images. The image on your left, you see a large, wide, idli-like fellow here. This is called acute EDH or extradural hematoma. EDH means looks like an idli like this, especially when it's large. Subdural hematoma looks concave or convex like this. So EDH, so what is EDH? You have the skull that is white and there's a brain, and over the surface of the brain has a covering called the dura. If the clot is outside the dura but inside the skull, it is called EDH. And if it is inside the dura but over the surface of the brain, it's called a subdural hematoma. And then you have here in the next scan, you see all these patchy, small white dots. All these are contusions in the brain with a fracture there. This is also large contusion left temporal region. The white is blood, black is edema, or what we call as swelling. Now, many times you would have seen patients whose skull is missing after surgery. The skull might have been kept in the abdominal wall, like in a pocket. Sometimes you will hear the skull was kept in the fridge, and sometimes it was put back after some time. Why do we neurosurgeons do this surgery? Now, as you understand, when you have an injury anywhere in the body, and one of the common body responses to injury is by swelling. And more the severe the injury, the more the swelling of the hand or the leg or what a face or whatever it is. And the swelling usually peaks by 48 to 72 hours. It is similar to the brain. When the brain gets injured, it starts swelling up. But the problem is, the skull doesn't expand. Because the skull doesn't expand, when you have an intensely expanding brain, there's a pressure cooker effect. And because of that, the center brain gets very jammed because of this. And all the life-saving controls are in the center of the brain, the centers for respiration and heart and everything else. And because they get impacted, patients die. So what do we do in that? We do a procedure called decompressive craniotomy, where we remove a big piece of bone and take it off and leave it in the abdominal wall or in the fridge so that we allow the brain to come outwards. So what do we do here? This is an example of a stroke patient where you had a large stroke. You see the half of the left side is black, which means there's a large stroke, and because of which we have removed this much of bone after surgery. You see this is a CT scan after surgery. This much of the white band is missing, which means the skull is removed, and you can see the brain coming out through this defect. So the central brain we have spared. So this is how the brain looks at surgery. Now you see these are the edges of the bone that we have cut with high-speed drill. This is the dura mater. The shining thing that you see is the dura mater with the bulging brain underneath that. Now I've opened the dura mater. You see the dura is open like a sheet on the side, and then you see the brain underneath here. This is all the blood vessels on the surface of the brain. The brain is as soft as cheese. So we have to be extremely careful in this. So this is how the brain looks. And then we look at it. We just put the dura back, but we don't stitch it up because we don't want to put the pressure back. And we put this white pieces called gel foam, gelatin sponge, just to cover the gaps of the brain that is exposed. And we do not put the bone back. So 6 to 8 weeks later, you see the skin is healed nicely, and this one has become flat, and then the bone is removed, and then the bone is put back. We have fixed it like this, and we fixed it with mini plates and screws and fix it back. So the key decisions in the checklist for a head injury patient. Why is this very important is because I have a lot of struggle with petitioners, lawyers who do not know exactly how to work up a case for getting a good evidence going so that appropriate compensation is given to the patient. First of all, is this a case of polytrauma? That means there's a head injury, there's a spine injury, there's a femur fracture, there's a humerus fracture, abdominal injury, whatever. If there's more than one thing, then you'll have multiple different injuries, means multiple disabilities. Those all have to be calculated separately and then put together. And if there's a head injury, if yes, you will look at the next set of data. Was there any external injuries, like I said, to the scalp, head, or face? If there was loss of consciousness, if yes, for how long? And you need to see the Glasgow coma scores. If I don't know how many of you are aware of it, we have something called the GCS, it's called the Glasgow coma score, and that is the standard coma scoring scale that is used around the world today. We are all neurosurgeons in trauma. So the best score is 15 by 15, which is you and me right now. The worst is 3. Lower the score, more severe the brain injury. Was there any epilepsy or seizures immediately after the trauma, or even a few days or weeks later? Did the patient undergo any brain surgery? If yes, was it on the same day? Was it one surgery, many surgeries? What type of surgeries? Was it on the same admission? Was it subsequent admissions? Was there a BP shunt port? Was there water collection in the brain? Was a borehole port? Was a craniotomy done? So many different varieties of stuff. So debridement, duroplasty, a lot of different things that we do depending on the underlying problems. Was the patient in the ICU, on the ventilator? Many times we have patients on ventilator for more than a month. And how long? All this means severe injury. The more lower the GCS at the time of injury, the longer the GCS is low, longer the patient remains unconscious, longer the ventilator, higher the chance of long-standing disability. Other thing you have to look for is tracheostomy. We put a hole in the throat here to put a ventilator tube, which we keep for a long, long time. Tracheostomy means usually moderate to severe head injury, unless it is a facial maxillary fracture because of which it was done. How long was the tracheostomy there? If it is only facial maxillary, we close it in a few days. If it's a head injury, sometimes weeks to months we have. Is the tracheostomy closed or the tracheostomy still present? How many days, weeks, months did the patient spend in hospital? Did he have one admission, multiple admissions? Was he transferred to a better hospital? All this indicates the severity and complexity of the injuries. Was he on a follow-up with the neuro specialist after discharge? Are these notes available? These are very important because most patients, the lawyers who are untrained in a neuro disability, especially in the beginning, and after I've trained them, I guide them, they're much better and they understand what is that. They come with a discharge summary and a wound certificate. Now, if the discharge summary is 2 years old, most of the discharge summaries does not tell functional abilities or disabilities of the patient. All this happen only during follow-up. So follow-up records is critical for in a neuro patient. If the patient does not have a neuro follow-up record, by a neurologist or a neurosurgeon, it's impossible for us to assess disability because it's a big struggle. Any further progress worsening during these visits, we had all made a notes there. What is the status and filing of the case? Was the patient not at the time of evidence? Was he conscious? Was he walking? Was he talking? And if he was not normal, was a neuro rehabilitation done? Physiotherapy, occupational therapy, speech therapy, memory therapy? What happened? What was done? So you see, this is how a tracheostomy looks in a moderate severe head injury patient. The tube in the throat, in the front of the throat. The one in the nose is called the feeding tube, and that's how the patients look. Now, GCS levels, like I said, we have the eye movements. We look for pupillary size and reaction. We look for hemiparesis, paraparesis, quadriparesis. Like I said, GCS 15 by 15 is normal people like you and me versus 2T or 3 by 15T is when the ventilator tube is put in place. The lower the score, like I said, higher the severe the brain injury, worse the outcomes, higher chance of disabilities. But remember one thing. So this becomes the next problem. So many times, I have had lawyers asking me this question in the box. What is the patient's GCS now? Is it 15? I said, yes. So they said, that means he is normal. So GCS 15 by 15 does not mean normal brain function. This is the second important message I want to communicate today. GCS 15 by 15 means normal level of consciousness. And unless the consciousness becomes normal, you cannot assess the complex brain functions. What do I mean? It's like me giving you a test in mathematics when you're half asleep and say, you didn't answer the question, so you failed. That doesn't work. Or you're trying to play cricket when you're half asleep. That's not, or I'm trying to do an operation when I'm half asleep. That's not going to work. So we need to be fully awake and alert even before we are tested for anything that is useful to know what is our actual brain capability. And only then the other complex brain functions can be tested. Now, Glasgow Coma score, I'm just going to run you through this very quickly. I don't have the time. There are 3 parts to it: eye-opening, verbal response, and motor response. E has 1 to 4, V has 1 to 5, M has 1 to 6. So E4, V5, M6 is the best score of 15 by 15. E1, V1, M1 is normal. I'm not going to go through this. This is the 4 things, 1 to 4. These are the 5 things in verbal response. These are the 6 things in motor response. That's how we score them. Now, like I said, 80% are mild head injury, LOC less than 1 hour, GCS is usually 14 and 15 at admission, 80% require no consequences, but 20% are persistent neuropsychological and cognitive symptoms. We'll talk about it later. Moderate head injury, 10%, LOC less than 24 hours, GCS 9 to 13 at admission, or the worst score, they can even worsen after a few days. 20% recover 1 to 6 months after TBI, but 80% present persistent symptoms and associated disability. So this itself, you would know in your case whether there is expected disability or no. So that's where I tell many of the lawyers where the head injury has been treated in a local hospital, and not seen very well by a neurologist or whatever, or they want me to come and give evidence. I tell them, the moment you file the wakalat, please send the patient to me for a follow-up. So one is I can do a regular follow-up and give him the right medicine so that he can actually get better, because there are a lot of things we can do to make the patient better. And then we can actually have the right evidence happening and the right guidance of the patient as he goes through the process. 10% is severe, LOC is more than 24 hours, GCS is the worst, 3 to 8 at admission. 100% have persistent evident symptoms, both hardware issues and software issues, and severity of symptoms highly correlated coma length and stay in the hospital. Now, this is the latest Gazette notification of the Government of India on disability. This was published on 5th of Jan 2018. It has a lot of gaps still. Unfortunately, I will take you through the gaps. Nobody from NIMHANS is a part of this panel. I do not know why. I am not the person to comment on, but there's nobody from NIMHANS on this panel. So for the second time running, even the 2001 Gazette did not have anybody from NIMHANS on the panel. And strangely, the word head injury, TBI, neurosurgeon, cognitive disabilities, not mentioned even once in this Gazette. I don't know why. I don't know what it means. How can it be done? And we are supposed to use this for assessing head injury patients when the word head injury is not even mentioned in this whole Gazette. Like I said, it's not been mentioned once. What does this mean? Does this mean there's no disability? I do not know who should assess this disability. Who can answer this question? Maybe the Supreme Court maybe have to answer this question. I really do not know about it. I'm really pleading with people to know why don't we define these things clearly, because otherwise the head injury patients are really not being served well. So this is the Gazette of here. You see this list. There's no mention. These are the 8 lists of 8 disabilities that I've looked at. Locomotor disability, including cerebral palsy, leprosy, dwarfism, acid attack, blindness, deaf and hard of hearing, speech language, intellectual, mental, chronic neurological conditions, but no head injury. So locomotor disability is, please read the definition. Locomotor disability means the patient's inability to execute distinctive activities associated with movement of self or objects, resulting from affliction of motor musculoskeletal system or nervous system or both. So you see, or both can be, so it can only be done by a neurosurgeon, not by an orthopedic surgeon. Why am I writing this statement is, I was giving evidence once in a head injury patient who had a right-sided weakness because the brain injury sustained, and he had what we call as right hemiparesis. So when I mentioned this, he's got a right upper limb and lower limb weakness. The learned counsel for the insurance asked me, are you an orthopedic surgeon? I said, no. Then how can you give limb disability? Limb disability has to be given only by an orthopedic surgeon. So I had to make him understand that this limb disability is not because of an orthopedic issue, it's because of a neuro issue. He refused to accept it. He asked me 5 times this question. So it was a very difficult thing to make them understand what is the problem. Now, like I said, measurable, non-measurable types of brain disability. I categorize brain disability under 3 headings. First is neurological, which is physical and visible. Like I said, the right-sided weakness, the hand like this, the head like this, the face like this, one eye closed. Those are neurological disabilities, which is physical and visible. Next is behavioral. Many of the patients' behavioral changes after head injury. Some of them become very quiet, they become withdrawn, apathetic, they're not in participating, they're like a social recluse. On the other end, other extreme, we have patients who are physically abusive, verbally abusive, beating up people, really, torturing people. It becomes such a big mess. Cognitive disability includes memory, decision, higher mental functions, logical memory, working memory, decision making, all those things come under that. So B and C come under the chronic neurobehavioral neuropsychiatric consequence of TBI. And A and B can be assessed based on a DGHS or the Government of India guidelines. C, there's nothing about C in the Government of India Gazette. So we use the NIMHANS guidelines. Like I said, it's not mentioned even in the latest Gazette. A is done by the neurosurgeon. B and C has to be assessed by the neuropsychologist or a clinical psychologist. But the neurosurgeon can interpret that and give evidence. Similar to how I send a patient to the MRI and CT scan, the technician does the MRI or CT, the radiologist gives the report, but I decide whether I have to operate or treat conservatively, and if yes to operate, what is the kind of surgery. It's a similar way to interpret because we know the full story. Now, according to NIMHANS authorities, the assessment should be done by the neurosurgeon and a neuropsychologist or a clinical psychologist combined. Now, how do I do the assessment? Assessment is based on the problems present at the first admission, problems during the journey of the hospital stay, problems during the follow-up, and the final problems when the patient comes with. Without these documents, I never give evidence. Because why is this? Many times the patient comes to me and gives a list of problems. And all the problems the patient is mentioning is never ever mentioned, even once in the last 3 years that he has gone to doctors. And if it is being mentioned by the patient for the first time, that means he's been tutored by somebody to go and tell this to the doctor so that you can get better evidence, better disability certificate, and that's not going to happen. Unless I am convinced about the whole process, only then the previous records justify that, only then we can actually capture it. It's a very, very important thing in neuro, especially to connect the dots together. So nowadays I've got wiser as I've done more and more cases. For many, many years now, I only ask for certified documents to come from the court. I do not want any document that's not certified by the court, because the same set of documents are available to all of us to see. It becomes very easy for us to refer to it, even if it's 1,000 pages. Then we need inputs from the patient. We need inputs from the caregiver. Very important, especially if the patient is unstable. Now in the Gazette, we call the impairment as permanent physical impairment, but it's called PPI. So what is a PPI? Neurological injuries. If altered sensorium means anybody who has a GCS 14 or less is 100%. Now, this information was present in the previous DGHS guidelines issued in 2001, but is missing in the current latest guidelines. Why? I don't know. So we have to now reach out to these people and tell them this. So I really do not know, how to take all this forward. I'm just bringing it. I'm not criticizing. I'm just showing you what all is going on so that everybody is on the same page on this understanding of this whole process. Now let us look at the latest Gazette, what is talking about PPI in neurological status. You see the number 10, guidelines for evaluation of locomotor disability in chronic neurological conditions. Chronic neurological conditions is a stroke, Parkinson's and things like that. They've used it more from the stroke perspective. You see, there's a lot of headings there. It's too much for me to read it right now because of lack of time. But there's a formula that we're going to deal it with later on. Additional weightage of 10%. Look at 10.7. It should be given if it is a dominant upper extremity. What do you mean by a dominant upper extremity? Like you all know, are you a right-hander or left-hander? Is a common question we all ask for different reasons. And we all know as human beings, 90% or more than 90% are right-handed individuals, only 10% are left-handed. And the left brain controls right side of the body, right brain controls left side of the body. And whichever hand is dominant, as what we call dominant for writing and dominant for throwing, and that side, that means the left brain is also dominant for speech. So we always understand that there'll be an additional speech processing issues and language processing issues in such people. And because they can't perform their work well, we give additional 10%. And if there's additional 10% is given for loss of sensation in each extremity. So, but remember, if there are multiple things, you should not cross 100%. We'll talk about it later. So you have the motor system. This is only for motor system. It is not for anything else. They use the latest Gazette talks of something called a modified Ranskin scale. You scale this scale very simply like this. And based on this, you have the MRI score of 0 to 5. And you see, if it is 5, it's more than 80% PPI straight away. Now, other neurological disabilities, sensory deficit, like I said, 10% for each limb. Another thing is, the big thing is bladder. If there's a bladder involvement, either patient is having increased frequency, hesitancy, he's leaking a little bit of urine every time he coughs or laughs, he's not able to control completely, or he's not able to pass urine properly, he's requiring a catheter, Just a bladder disability itself can literally lead to 100% disability as far as this gazette notification. And ataxia means, unsteadiness while walking. It's like when people are drunk, they walk. That's a simple way of making people understand ataxia. Now, ataxia percentage can be less than 40 to 60, or even more than 60 with this. All these things can coexist. So you can see how much disabilities are there. Now look at the speech and language. Look at the definition. Speech language disability means a permanent disability arising out of conditions such as laryngectomy or aphasia. Laryngectomy is local voice box cancer. Aphasia is because of neurological causes. And if you look at this list at the bottom, except dysarthria and apraxia, rest of it is all local problems. Now, intellectual disability we go to, this only mentions children with learning disability. There's no head injury mentioned here at all. Look at the definition. A condition categorized by significant limitation in intellectual functioning, reasoning, learning, problem solving in adaptive behavior, and is predominantly for children. That's why we use, because this is the limitation in this gazette, we use an enhanced head injury battery. NIMHANS has a standard head injury battery that's universally accepted, and we use that battery. Mental illness. Now, like I said, the neuropsychiatric, neurobehavioral problems of the head injury is significant, and we use this Indian the scale called the IDEA scale, Indian Disability Evaluation Assessment Scale called the IDEAS, which has been designed by the Indian Association of Psychiatry, and we use that. And based on that, we categorize them. If you see 23.4, it says IQ. So many people ask me in the court, have you done an IQ test? Now, IQ test is only done as per NIMHANS recommendation if the standard, more complex neuropsychological assessment cannot be done. So IQ is a very primitive way of testing. It's like giving an internal assessment test for 20 marks and then expecting them to extrapolate that to 100 marks, or like playing T20 cricket versus a 5-day test match. The capabilities and the results are very different. According to my expert, like I said, is only done in formal assessment, cannot be done. Again, the head injury battery is not a part of this gazette notification. Now, disability to chronic neurological conditions, it says only 2 diseases, multiple sclerosis and Parkinson's disease. That is it. Why? I don't know. Now, look at multiple disabilities. You have a long list here. In this whole list, there is no head injury. Again, it's very strange. Now, epilepsy. You can have epilepsy after head injury. So this we call it post-traumatic epilepsy. This can be early post-traumatic epilepsy, late, or intermediate. Early is within 7 days of injury, 5% have it, 25% further episodes, a good prognosis. Those who get epilepsy after 7 days because of the scarring in the brain usually reflects brain damage, and 75% of such people will require long-term medicines. There's risk of driving and swimming. According to the Indian Motor Vehicle MVC Act, any patient who has had even one epileptic seizure is not permitted to drive for the rest of his life. Which means if your patient is a driver by occupation, he may be a public, like a bus driver or a taxi driver, they come and tell me, otherwise they look okay, says, give me a fitness to drive. I said, I can't give you the fitness because you have the risk of epilepsy. And even if you have this, thing for 5 seconds, it can be disastrous. I may be sitting in the bus, and if something happens, not only you will be put inside, I will also be put inside for giving you the fitness to drive. So I have to give a letter. He is fit to do non-driving related activities. That means any activity that puts his life at risk or other people's life at risk should be driven very strongly in the court. Like, for example, if the patient is an electrician, if he's a mason, he works at the 2nd floor, 3rd floor, works at heights, and he has an epileptic fit there. Think about what's going to happen. He's going to fall down. Imagine he's a machine worker. He's working in front of a lathe machine or some very risky situation like that, and he has an epileptic fit and falls onto the machine. It can be a big problem. So based on his avocation, we have to also realize what is happening, and this can become a serious avocational disability. Now look at this post-surgery fits. There's a percentage of disability based on the fits. And again, this post-epileptic convulsions was there in the 2001 Gazette. This is not covered in the new Gazette. Again, I do not know why. Now, evaluation of strength of muscle, we will not go through this. Now, vision assessment, why have I put here is because a lot of time the controversy is who assesses disability. Is it an ophthalmologist, eye specialist, or is it a neuro specialist? So look at this scene. So you see the eye globe here. The ophthalmologist only treats this ball. Once it exits the eye and gets into the brain, the rest of this is our business. So when the brain injury happens and the damage is here, like that advocate who had this injury, then it's us who have to give disability and not the ophthalmologist. Hearing impairment, like because of ear bleed, that can be tested by the ENT surgeon with the audiometrist. Amnesia, like I said, loss of memory. Now it's a very simple word. Now the two types of amnesia post head injury. One is called pre-traumatic or retrograde amnesia, and post-traumatic or anterograde amnesia. What is pre-traumatic or retrograde? Amnesia to the event and variable period. Now, it can be from a few seconds to a few months or even years. Like, for example, let us say a patient had an accident at one signal junction. He may remember till the previous signal junction. After that, he's forgotten that last 1 minute or 50 seconds or 30 seconds when he had the accident. So he's amnesic to an event that has happened. Or he may not remember what happened that whole day or previous day and things like that. That depends on how severe the head injury is. I had an MBBS doctor who was halfway through his internship. That means past his MBBS doing internship when he had a very bad head injury, recovered with some weakness of the hand and leg, and he came to me for disability assessment. And I realized when I really took a detailed history and evaluation that he remembered only his first MBBS subjects. After that, he has no idea. Now, here is a doctor who's got his medical certificate done. He's got his degree certificate. He's passed all his exams, but because of the head injury, he's forgotten all of it. So it can become a serious problem. So many people have forgotten the prior knowledge, the businesses and skill sets. Now, none of this can be assessed by a standard blood test or an MRI scan because each of us are different. These skill sets are different. Very, very important to remember this. Now, what is post-traumatic amnesia or anterograde amnesia? That means amnesia to events going after the accident. Now, this is the period before the patient gets full orientation and continual memory. That means it again connects severity to injury. For example, if the patient was staying in the hospital for a month, and many of the patients don't even remember staying 1 month in the hospital. When they don't remember me having seen him and treated him. When they come back during follow-up, they come and tell me, doctor, I heard you are the one who saved my life, who operated me, blah, blah, blah. Thank you very much. Some of them remember the last 1 day or 2 days. So the longer this anterograde amnesia, again, means more severe the injury. Again, this memory will never come back. So the family has to just update them and say, this is what happened to you. This is what it is. Why is this important for me to say this? Because what happens is many untrained petitioner lawyers, before they come to us for assessment of disability, have already put the petitioner in the box. And they are given an evidence on the petition. They have made the petitioner say, oh, I was traveling on this road. I was hit by this vehicle carrying number plate number so-and-so. I fell on the road. I had this problem. In first person, I was taken to this hospital. I was taken to that hospital. That means patient remembers everything. To honestly, today, even my own car number, I don't remember very well. Is it MD or MR? Sometimes I get confused. So what happens is when the petitioner's lawyers thinking that the more they give evidence like this, it's going to be better for their case. And I have to go next and tell that because memory is okay. The first thing the insurance lawyer says, sir, he has told all these things in the court. So one of you have to be wrong. So it's very important to understand by giving all these details, you can even actually be harming your case and shooting yourself in the foot rather than the other way around. So that's important. My message, without knowing these details, like I was saying this, I call it professional harakiri. I apologize for saying this. A majority of petition lawyers are seeing this as a money-making opportunity. I'm not saying no to that. But it's not a business. These patients need help. And if you really serve them well, I'm telling you, there is enough compensation the court will give. But not having the knowledge and what documents are required to be provided in the court, you're harming your case. But giving the right documents, you strengthen your case. So that's what helps us to give maximum disability. Very important third message I want you to communicate today. Now, another important decision for the honorable courts and judges to make. So is this patient's evidence going to be reliable? Now, this is the next thing. Because the thing is, if this patient has head injury, his brain is not okay. Now, it's like asking a mentally retarded person to come and give evidence in the box. How reliable is that guy's evidence going to be? So it's very important for the court to decide and for the petition law to petition to say, my patient is not stable. I don't think he can give a reliable evidence. I want to now give his best friend or family or whatever it is to do. That's what we call as, a guardian is to be appointed. And my request to the honorable judges, if anybody is here on this or all you people, please petition them. Many lawyers are not aware how to do this in the sense of not to guardian, but how to assess it. So NIMHANS, sometimes the court can take a suo motu decision, but NIMHANS says if the neuropsychological disability or cognitive disability is 40% or more, then the patient's evidence is going to be unreliable. And the next best person has to be appointed as the guardian, as the petitioner in the case, which means that the evidence has to be done differently. So head injuries, headaches are very rarely seen in severe head injury. Very commonly seen in this PTSD. I don't know how many of you have heard of this phrase called PTSD. It's called post-traumatic stress disorder. It's a very, very big psychiatric issue that is happening. And you see this, especially in, you will hear it everywhere. But the big problem is happening in American war veterans who are war victims in Afghanistan, in Iraq. They are all struggling post injuries and recovering and coming back, and they've been out of service because they're disabled. PTSD is a very big issue. They're really disabled for life on a moment-to-moment basis. It's very distressing. Dizziness and what you call talasutta, the head spin, circa chakkar is what they say. This can be very very symptomatic, but we have no way to measure this. Patient have to say, and we have to believe it. Poor concentration, some people have attention issues. Again, we can't measure it. Patient has said, we observe it as the patient is spending time with us. We understand what's happening. There's something called a post-concussive syndrome, a combination of all the things I've been speaking about. Remember, none of this can be measured, but it's severely disabling. It's like an unknown virus in your phone or system that's slowing it down or not giving proper outputs. And that's how similar it is. You know how frustrated you are when the upload doesn't happen, the download doesn't happen, and message doesn't go, or something else doesn't happen. It's so frustrating that that color wheel keeps on turning. This is what is happening in many people's brain. The color wheel is turning, and nothing much is happening. No download is happening, no upload is happening, or not fast enough. Anosmia, this is another big thing. Today, anosmia means loss of smell. Probably before COVID-19 came in, nobody would have bothered so much of sense of smell. Today, everybody knows anosmia because one of the consistent early symptoms of COVID infection is loss of smell. So I hope all of you know about this. Even if you don't get a florid COVID infection, if you have lost smell, you have a risk of having developed contact with COVID-19 infection. So why is this important in a head injury patient? So imagine when they have a skull-based fracture, even in the back of the head, when the head goes back like this, the front here, the smell nerves that comes to the nose gets yanked away. So it's seen in 7% head injuries. And why is this important? Because imagine if the patient is a housewife, she can't smell a gas leak. The patient is a cook, he can't smell a gas leak. He can't smell a kerosene leak. And suddenly he puts on the switch, or he's managing the generator in the generator room, or he's some other place. Can you imagine if he can't smell the fire burning? It can be a serious problem. So you have to connect it to their avocation and give an avocational disability. So the percentage of disability of the neurological disability of the whole body disability may be 10%. But if their avocation is having this as a big part of it, avocational disability may be 50%, maybe 100%. So we have to decide for that avocation. He may be able to do some other avocation, but for that avocation, not possible. Facial nerve palsy, one side of the face that's paralyzed. You can have, the eye may not close in some patients. The face will be crossed to one side like this. But apart from cosmetic, it doesn't cause too much of functional disability. Yeah, some problems with chewing, some drooling of saliva, that's the way it is. Remember, the psychological, social, and behavioral disabilities as well as cognitive disabilities can only be assessed in conscious patients who have adequate attention span and understanding the language properly. So this is a high-end assessment that can happen only when the patient is having all this. This is the next level of message, take-home message I want you people to remember. Now, this is done. The process, the head injury battery I was called, is done by neuropsychologists. If you people are interested, we can have a 2-hour class just on that. This is done by neuropsychologists. There is a battery of 21 tests to be done, which is designed by NIMHANS. In a normal person like you and me, to assess the neuropsychological or cognitive function of a patient takes 3 hours. If it is a disabled patient, it may take 4 hours, 5 hours, 8 hours, 10 hours, which means obviously they're not done it together. They break it up into many days and to do it, and we can know what is happening and we can give disabilities based on that. So far is only about head injury or brain injury. Let's quickly go to spine and spinal cord injuries. Spine is different, spinal cord is different. Spine is the bone, spinal cord is the nerve. So all of you know, this is how the spinal bones look. You have the vertebral body, you have the pedicle, you have the spinous process, you have a lot of things, and this hole in the middle that you see here, the small hole in the center of the vertebral body is where the spinal cords travel. And if you see the structure of the bones are different in cervical, thoracic, and lumbar regions, and that's how it goes. You have the spinal cord ends at L1, but the spinal bones go up to S1, and coccyx beyond that. So you got a lot of nerves coming out. I don't want to talk about any of this. Related to, we don't want to. You can have fractures, subluxation, or dislocation, or slip. You can have a slip disc without a fracture. You can have an extradural hematoma, subdural hematoma like in the brain, or you can also have somebody, elderly person who already had cervical spondylosis, lumbar spondylosis, on which he had this. Classically, the bus fuller jammed his brake. The patient's neck went forward and backward like this in the seat that he's sitting, or maybe went and hit the the bar of the seat in the front, and you can have a serious cervical spine injury. These are called whiplash injuries. Sorry. You can have central cord syndromes, cord contusions, and hematomas. Remember, only spinal cord injuries cause devastating and lifelong neurological disabilities. Any fractures of the spinal bone or soft tissue like a slip disc may cause pain and very small deficits, and not as much as a spinal cord injury. So you can have a bone injured with no spinal cord injury, which is much smaller, even if you have 10 fractures there. So you can have multiple spinal related fractures, even soft tissue without a spinal cord injury, which means the disability may not be much. Let us look at what the Gazette talks about PPI, evaluation of physical PPI in spine. You have traumatic lesions, cervical. I'll just cut it and show you a few things. In cervical spine injuries, you have because of compression, posterior element damage, severe dislocation, disc disease, all that percentage. And if there are multiple things, you have to add all of this to it. Thoracic, thoracolumbar spine, the calculations are different. Lumbar sacral spine, the calculations are different. Multiple spines involved, calculations are all cumulative. If there's a disc prolapse, intervertebral disc lesion, the calculation is additional. Spinal cord injuries, calculations are different. There are a lot of different ways to make the calculation happen. You see here tetraplegia, which means quadriplegia, all four limb injury. It can be percentages up to 90%, paraplegia up to 75%, cauda equina syndrome without bowel bladder 40%, with bowel bladder 60%. So it's very clear how big the disabilities are. So we have to justify it, we have to write it well. We have plexus injuries. So once the nerves exit the neck, the cervical spine, or in the back, they come to the upper limb or the lower limb. They're called the brachial plexus or the lumbosacral plexus. So you can have injuries at this level. Classically, when the patient falls like this, the head goes like this, the shoulder goes, arm gets pulled. Classically is when you're falling from a height and hold on to a rope and the hand is held and the rest of the body is going, to get brachial plexus. This is also commonly seen during childbirth, when the child's arm comes out first for some reason, and the doctor by mistake holds the hand and tries to deliver the baby out, it causes a brachial plexus injury. For this, we have Proforma 1A and Proforma Form A and Form B in Appendix 2 of the Gazette. So you have the assessed Proforma for upper extremity, which is Form A. You have a long list of things here. You have an hand component, and you have the prehension, opposition, a lot of things. Like I said, again, 10% for upper extremity. Then you have a lower extremity, which is Form B. You have a mobility component. You have a stability component. You look at all these different things and look at how it works. Now, like I said, plexus and peripheral nerves, you use Form A and B depending on where it is. Now, multiple disabilities. How do you assess multiple disabilities? Now, somebody is given 10%, somebody is given 50%, somebody is given 80%, somebody is given 70%. If you total all of that, it can come to 200%. But obviously, it can't cross 100%. So the Gazette has clearly given us guidelines how to assess multiple disabilities. There's a formula for assessing multiple disabilities. This is called the DGHS's Director General Health Services, Government of India. It's called the telescopic sum formula, where you have A plus B into 90 minus A by 90, where A is the first or the highest disability, B is the second highest, and so on. So we use something called a board mass that we learned as a child in school. B is bracket, O is off, D is division, M is multiplication, A is addition, S is subtraction for the calculation. Let me give you an example of how to use the formula. Step 1, this is how I would write a disability assessment. So I will write, as per the DGHS Government of India guidelines and the enhanced guidelines, the neurological disability is a minimum left side hemiparesis with apraxia, which is 10%. The neurobehavioral disability, as per the IDEAS, is 24%. The cognitive disability is 26%. Now you see, A is the highest, which is 26, B is 24, and then the lower one is 10. So let us use it in the formula here. A is 26, B is 24. When you use the formula, you get a value called 43.06. Now 43.06 becomes A. And now the third fellow that's hanging on becomes B, which is 10%. Now you put A there and B as 10%. Now the fresh disability becomes 48.27. If you actually total all these three, it is 20, 20, 40, 50, 60%. If you add it all together at 60%, if you use the formula, you get 48.27%. That's how this percentage comes down and becomes more realistic. So what do we say now? The final whole body disability due to permanent physical impairment in neurological conditions is 48.27%. Neyman says, and that's what we follow, we never tell final disability or permanent disability until at least 12 months have passed after head injury. A lot of lawyers are very, very in an urgency to do the case within 6 months. I tell them very clearly, if you're coming within 6 months, the current disability, it may not be permanent, patient can improve, then we say current disability. It's like trying to give an as disability of the lower limb even before removing the plaster and doing physiotherapy. So that's all from me. I'm sorry I've gone through this in a hurry, but thank you very much. These are my contact details. My name is Dr. Sharan Srinivasan. My mobile number is this, and my email ID is this. Thank you very much.
Thank you, Dr. Sharan. I could understand that you were rushing across once you said that it was a 6 hours, what you did at the academy, and we have rushed it in a 1 hour. But still, the compressed form could be well understood. And for me also, there were some eye openers because I am also doing one of the cases where the doctor had said that with the flux of time, we could improve. That is a separate case. I was in an appeal, though we thereafter again the question the PJ again submitted the report. Yes, we concurred that what we had said it will improve, but it hasn't improved.
Correct.
The matter is still pending.
So many times what happens is you can even do an assessment 6 months apart. And if you demonstrate that both are the same, that means it is permanent, it's not improving. But I have seen many times with the good neuro rehabilitation, I don't know how many insurance lawyers are there on this panel of those listening to me, that I have seen patients initially when I have done a pre-rehab assessment, patient's disability is 65%. And after good rehabilitation, the disability comes down to 17%, 20%. So actually, it's a very big thing, the difference that can happen with good rehabilitation. And that also should be considered because whatever the courts give as a financial compensation is only notional at the end of the day. Really, you want these patients back, on their feet, managing themselves and, being productive citizens of this country because this country cannot afford disabled people. And that's the reality. But what Modi ji keeps talking about the demographic dividend of this country, these are the people who are the highest risk of having road traffic accidents and head injuries. And if all these people start becoming, disabled for the next 20, 30, 40 years, imagine the stress on the system. So it's very, very important for us to understand how we can minimize this so that the family is not dysfunctional. It's not just the patient. The family becomes dysfunctional.
One has asked, kindly share your email ID. Could you just share the last slide?
Sure.
I
will share. Sorry about that.
Mobile number.
You have to allow me to share again.
They can have a screenshot. They can always have a screenshot of that.
Yeah. You have to allow me to share. It's not allowing me to share. Right.
Yes, allowed.
Yeah. He's allowed. That's my phone number. That's my email ID.
Yeah. Those who want, they can have a screenshot of this. And those who want, they can contact on the WhatsApp. We can share the mobile number of doctor. And only one question has come. Is the accident register admissible as evidence in these cases?
Sorry, I didn't hear you.
What is the significance of the attendance register? Admission register?
Sir, I'm not able to hear you. I'm sorry, your voice is breaking.
I'm just read the last question of Iftikhar Ahmed. It says
drowsiness is a side effect that person. Yes.
In case a patient is on.
Yeah, Neurosurgical P. Neurosurgical is just a nerve-strengthening vitamin. The P causes drowsiness. And obviously, he cannot drive. So the reality is, normally we prescribe Neurosurgical P at night so that they sleep well and the drowsiness during daytime is not much. But for some reason, if the burning pain is too much, then it's given twice a day. At that time, you should tell them not to drive for sure. They should not be able to drive. But normally we give it for 3 or 4 months and stop it. But in case somebody has to take it long term, normally what we have seen with these kind of drugs is after 3 to 4 weeks, the drowsiness goes away. The body gets used to it. So if it is persisting, he has to drive, the medicine has to be changed.
Yeah. So it was quite a technical session. So probably they can only take the good feelings.
I am sorry, I have to rush through because I told you it's an extraordinary session. I want you guys to see how complex this thing is, and I'll be more than open to have more reasonable sessions where I can go slowly and sort of have it.
We will do that. We will do that.
In a better way.
I can gather that people have actually enjoyed that. We will definitely have one.
Fair enough. Because I'm committed, to ensure that the legal system gets the right data, so that they can present their case properly, so that the patient gets the right benefit. Because that's whole thing is we want the petitioner to benefit. And
that's true. So both, what could be the reasons of frequent dizziness?
So it can be to the neck injury. You see, the dizziness or giddiness, what we say is three things. Either it's because of the brain, because of the ear, or because of the neck, or a combination of the three. So that's what happens. So whenever they change their position suddenly, there's the balance mechanism. The brain takes a little bit of time to get adjusted to it. And at that time, it induces giddiness. That's what happens. Commonly, they see when they get up from bed, they get up from standing position, they suddenly turn, they look into the wash basin and things like that. They have this giddiness.
No, certain aspects like what you told about epilepsy, that is also one aspect which one has to consider. One thought that is like a normal, the action of epilepsy.
Epilepsy, that's right. Yes.
Because normally people feel that epilepsy people are driving. I know a lot of people who suffer.
Yes, they are driving. It's not with yes, it's very unfair.
Yeah. No, you are discussing about a normal case.
Correct.
But what about a normal person who is suffering from epilepsy?
Even they cannot drive. It's not just because head injury. Even a normal person. See, I'll give you an example. 10, 12 years ago, we had a BMT, one of our public transport buses in a crowded high main road in Bangalore city, went off the road or onto the footpath and killed 6 people. And why that happened was the driver developed an epileptic fit, not head injury, epileptic fit. He was fine after this once he woke up, but he killed 6 people. So we can't be allowing them to do that for sure. Even 5 seconds, think about it. In this Indian roads today, even one moment you remember this Saif Ali Khan's movie of he was looking at the text, he was texting and driving and, he killed a couple, some movie was there and he has to take care of those 2 children of that, couple. I mean, there was a story that it's like that. So even texting is bad, we know that. But then even if you 2 seconds, 3 seconds, you lose it, especially when you're at high speed, it can be disastrous. And one more gentleman, Mr. Arif Anwar, has asked, yes, of course, NIMHANS is it's not just a government of India institution, sir. It's an institute of national importance. There's a NIMHANS bill passed by Parliament. Of course, it's a recognized guideline. Unfortunately, it's not in the Gazette, but we are using it because it's a government of India. It's an institute of national importance. And we have the, the honor of having NIMHANS in Bangalore. So we get to interact with them. So we get more information from them.
There's another by Nidhi Anand.
So Mr. Iftikhar has said something. Sir, obviously I cannot answer these questions without knowing the reason it's been prescribed and things like that. I would recommend him to go back and tell his doctor that he's having this struggle, and the doctor insists that he needs this drug, and then he cannot drive, sir. That's a very simple thing. It's like you can't have the cake and eat it also. Somewhere you have to put a balance between the two. It's like a diabetic saying, I want to eat the sweet. I want to have my diet sugar under control. Is not going to happen. You have to give up something to get something. Yeah. What are the chances of stroke medicine? It's not about if the stroke if any neurological issue has not recovered very well within first 6 to 18 months, whatever remains behind will remain. It will never become normal 100%. But with some good rehab, maybe another 5-10% of functional improvements can happen. This is to Ms. Nidhi Anand's question.
Yeah, I could get it. So we had a fantastic session. There's another question by Arif Anwar. VSMS scale can be used for adults as an assessment?
Yeah, yes. Before that, Mr. Jaideep Singh has said, it's the disability is not in percentile, Mr. Jaideep. The disability is in percentage. Only the cognitive disabilities are initially given in percentiles, but then they're converted to the percentage by a formula that we use. The percentiles are for the scoring of each test, But when you convert to disability, it's always in percentage. So there is a formula for that. If you want to know simply the neuropsychological thing, number of tests done per number of abnormal tests, into 100. BSMS again is done when even the IQ cannot be done and the neuropsychological assessments cannot be done, Mr. Arif. And then we do the BSMS to look at the social scale. It's a very primitive, very basic scale. And that if your patient can be assessed only by a BSMS scale, he's grossly disabled.
Yeah. So thank you, Dr. Srinivas. The questions which have been posted, and it will be always a pleasure to connect back on this platform and otherwise also. And before we part for the day, tomorrow the session would be on attachment and sale of immovables in execution of a decree. It is by S.R. Surendrana Rao, an advocate from Chikalpur, Karnataka. So do stay connected with us at 5 p.m. tomorrow, and we will connect with the doctor once again. And thank you once again on behalf of all the participants who have been watching us live on the Facebook, YouTube, as well as on this platform.
My pleasure.
Thank you, everyone. And once the doctor is there, everyone stay safe, stay blessed.
Wear helmets with the buckle.
Have a great day.
Yes. Most important, right? Thank you. Bye-bye.
They may not take your advice so seriously that even with the cars, they are wearing the helmets.
I agree with you. Absolutely. Right. Thank you.
Then they would have said that it's a doctor.